Hello, class. Now we're going to start talking about some of the uh, urinary problems our patients may experience. Now, some of these are not so severe that your patient is going to be hospitalized with them, but sometimes these unfortunate infections occur while the patients are in the hospital. So they occur after a patient is admitted. Many times UTIs can be an issue, especially if someone has had a indwelling catheter in for a long time. So it just is important that you're aware of some of the manifestations that can occur, and also to be on the alert that when a patient does have a urinary catheter, that they are at a potential risk for acquiring a UTI. That's why it's so important that we get that fully out as soon as possible, because it is a foreign object, and we have to assume that it was put in under strict aseptic technique, but sometimes that doesn't always happen, and the longer it's in, the more chance a patient will have of acquiring a UTI. Now, there's a lot of factors that will contribute to a UTI and someone getting cystitis, which is a very common UTI. It's basically a infection in the bladder. One of those factors could be an obstruction. Maybe someone urinates but really doesn't fully empty their bladder, so there is some incomplete bladder emptying, which gives a sense of residual, so the patient is at risk for acquiring a UTI. Stones are another reason, because large stones can actually obstruct urinary outflow, especially when they're lodged in the ureters. The vesicuratorial reflex, when you have reflex back into the bladder, that's a very serious situation, especially when our patients might have an obstruction and you don't have that downward flow of urine. Many times as that urine ascends upward, patients can develop pyelonephritis, which we'll talk about probably tomorrow in class. And with that, a patient can end up with kidney scarring. And, think back to when I talked about how urine is made. If you've got scarring on those tubules within the nephron, you could definitely have some issues with absorption and secretion of certain electrolytes and, of course, water. Diabetes. When there's an excessive amount of glucose in the urine, it makes for great media for bacteria to multiply. The characteristics of urine, remember we went back, if you go back to talking about what the normal pH of urine is, we'd like it a little bit more on the acidic side, because the more alkaline urine is, the more chances of a UTI. Alkaline urine is another great media for bacteria to kind of reproduce quickly. Depending on gender, obviously women are more prone to urinary tract infections because of just the way our anatomy is. Age, the older you get, there's a lot of these other factors like retention, things like that. Sexual activity, and of course recent use of antibiotics kind of kills out some of the normal flora and the defense mechanism, so it again makes a good media for the development of a UTI. Now, we're going to talk about cystitis and urethritis and incontinences and things like that. And I think it's always important to know that urinary incontinence is not a normal part of aging. It's a problem, and it can be a very serious problem for some women as well as men, especially elder men who definitely develop prostate problems. And we'll talk about, some of the interventions we can kind of encourage our female patients to kind of partake in, and many times incontinence can be so severe that sometimes surgical intervention is necessary. So we'll get into some of these ways in which we can help patients with some of the different types of urinary incontinences, and then really talking about urinary tract infections. And the reason this is a very important topic is we are very concerned about the elderly, because many of the elderly patients, things start to change as far as thirst sensations. So dehydration is a big issue with the elderly. So and when elderly patients or elderly people do have incontinence, they tend to think that this will not be so bad if I don't drink as much. So they tend to kind of go easy on the fluids, get dehydrated, end up with a UTI, and then let all those manifestations begin to occur. And what happens is they end up with a full-blown UTI, which can lead to urosepsis and even death. And many times, as I said before, some of these infections become infections as the patients are admitted in the hospital, and we call those nosocomial infections. And that's why it's really important that, in the elderly, we make sure that there is no barriers or obstruction to voiding or micturition, because when residual occurs, that's where patients get into trouble and end up with UTIs. So let's first talk about cystitis. Cystitis is basically an inflammation or infection of the bladder. It can be caused by irritation, infection from bacteria, from a virus, from a fungi, or from a parasite. And infectious cystitis is probably the most common. And you can also have non-infectious cystitis by chemicals or radiation, but that is obviously less familiar and less frequent to happen, okay? And most of these infections called cystitis are caused by E. coli or catheters in the hospital. This is interesting facts, is 50% of patients in the hospital with indwelling catheters will become infected within 5 to 7 days of insertion of that catheter. That's why we have to be very proactive and determine what's the reason that this patient has a Foley catheter. Is it necessary that they continue to have one? Because there's a lot of other issues besides the possibility of getting an infection. It also makes that sensation of feeling that you have to urinate start to decrease. And because the bladder kind of tends to get lazy because the Foley's in there, and you don't have that stretching of the bladder because the bladder really never gets a large amount of urine in it, so that let's say normal way in which we are aware that we have to void is gone, because the Foley catheter is now in, taking the place of the ability to void on our own. Urinary tract infections are very common. About 5 million people a year will be treated for a UTI, but cystitis is preventable. Sometimes this occurs because a person may have changes in their fluid intake. That's why it's necessary that someone takes in a minimum amount of fluid a day, anywhere from 1.5 to 2.5 liters a day. And it's really quite important that what kind of fluids are they taking. Water is probably the best choice rather than a lot of these sugary drinks, pops, sweetened iced tea, things like that. So that's pretty much some of the reasons why people, particularly women, acquire cystitis. A lot of times it's just poor hygiene or the lack of knowledge to know that it's very important to wipe from front to back. And as I said, that's probably one of the main reasons why women particularly get UTIs. And of course, I just mentioned the threat of infections from catheters, okay? Remember, this is a very common infection and kind of presents with the typical inflammatory reactions that occur. You know, fever. Patients will begin to develop dysuria, which is painful urination, have that urgency to urinate. You know, they may only have a small amount of urine in the bladder, but just feel like they have to go lots and lots. Nocturia, urine may also be a foul odor. It may appear cloudy, or even with some very serious cystitis, patients can actually have hematuria or blood in the urine. And that's just because there is bleeding or irritation of that inflamed wall of the bladder. Remember, the mucosa in the bladder becomes very hyperemic, which means red, and actually may hemorrhage. And in an inflammatory process, that's where you can see a lot of pus form, and that's what kind of is responsible for making that urine very cloudy and foul smelling. If you've ever had, you know, a UTI, it's a very painful, very uncomfortable situation, and it just really makes you feel sick. You just have those typical symptoms of general malaise, may even have a little bit of nausea and vomiting. When you suspect that yourself or a patient may have a possible UTI, the best thing is to get a urinalysis. And we kind of want to have that urine analyzed. You'll be able to see when you collect the specimen, you know, just exactly what the character of that urine looks like. They'll check for that leukocyte esterase, which is that enzyme associated with white blood cells. And they might do a urine for CNS, because we want to kind of culture it before we start them on an antibiotic to see what is the organism that is definitely causing the infection. And like I said, most of the time it's frequently caused by E. coli. At this point, we want to help relieve our patients with the symptoms associated with a cystitis. You know, Tylenol, encourage fluids, and then of course get them on an antibiotic as soon as possible. And really begin teaching about good hygiene after bowel movements, to make sure that they're wiping from front to back, that there's no chance of any E. coli getting into the urinary tract system. Urinary tract infections are pretty much the most frequent reason why people seek medical help, secondary to respiratory infections. And as I said, they're very common in young women and very unusual in men under the age of 50, because by that time the prostate begins to enlarge, and prostatitis is probably the main reason why men over 50 end up with what we call a UTI. We see about 2 million men a year in the office for some type of UTI, and about 8 million in office visits. Cost our healthcare system about $3.5 billion a year. And as I said before, sometimes even very sexually active women are more prone to UTIs. Even some of the spermicidal compounds with diaphragms can even be more of a cause of why women get UTIs. Because depending on their defense mechanism, some women do lack that protective mucosa. And as I said, men, the most frequent reason after 50 that they get a UTI is from BPH, and they'll get some type of bacterial prostatitis. So that's, you know, many of the reasons why people are more prone to UTIs. even men who are circumcised. That gives a protective effect against UTIs for women. And of course, urinary tract infections can be caused by obstruction from tumors, kidney stones, strictures, or even impaired bladder that might have some kind of structural problem. Remember, diabetics are much more prone to UTIs, even women who are pregnant, particularly in the last trimester. Remember, it's really a defense mechanism that we go to urinate at least, anywhere from 3 to 5 times a day. We could have been equipped to hold up to 2,000 mLs in our bladder and then just go once a day. But really, every time we urinate, it kind of gives us a flushing effect of ridding the entrance into the urethra free of bacteria that may be harboring there, so that it won't get into the urinary tract system. That's kind of the reason why it's really important to make sure that the bladder is emptied out fully, because any type of residual can really be a great media for bacteria to grow. When we talk about urinary tract infections, and we've talked specifically about cystitis, those are some of the lower UTIs: cystitis, prostatitis, and urethritis. Some of the upper UTIs that we'll get into later on is pyelonephritis, acute and chronic, interstitial nephritis, and some of the renal abscesses and perirenal abscesses that may occur. Okay. And as I said, probably one of the most frequent bacteria that cause UTIs are E. coli, but we also see things like Klebsiella and Proteus also. So, when the first time a patient may voice concern that they're having burning upon urination, or maybe they're urinating a lot more frequently, might be time to kind of investigate to make sure the patient doesn't have a UTI, especially if they've been on a lot of antibiotics for other infections. Pain, burning frequency, nocturia, sometimes incontinence, and hematuria. If these infections get real bad, these patients can also develop suprapubic, pelvic, or back or flank pain. And really, many times, as these patients who are elderly get a UTI, they can really have extreme changes in their mental status, which could give you an idea that maybe they're becoming uroseptic. To avoid UTIs, it's really important that we only use indwelling catheters if they're absolutely necessary, and that if they do have an indwelling catheter, that we are properly taking care of those and only keeping them in as long as necessary. Encouraging and teaching about good personal hygiene, avoiding tub and bubble baths, to urinate after sex, and sometimes when these infections get to be quite full-blown, that we encourage a person to apply heat to the perineum to relieve pain and spasm. And then, of course, drinking a lot of fluids as long as it's not contraindicated. Another type of cystitis that is least common is interstitial cystitis. It's a chronic inflammation, really unknown etiology. It is a cystitis that kind of presents its way a little bit differently than the typical cystitis that I just got done talking about. Interstitial cystitis is rare, and we see it affect women about 10 times more. Really manifested and characterized by voiding at least 40 to 60 times a day, more intense urgency, and along with the urgency, there's a lot of suprapubic or pelvic pain. So it kind of presents a little bit differently. with your typical cystitis that I just got done talking about, when we see this occur, 2-3 times a year, that's probably a red flag that something's going on, and your healthcare provider may encourage you to, or the patient, to have a cystoscopy to kind of look inside the bladder and see what may be the cause of these frequent bouts of cystitis, especially if they haven't had a catheter or anything like that. So that's pretty much cystitis, and it is an infection of the urinary tract system, and I think it's important to understand that we need to clear this up as quickly as possible because we don't want it to lead to a urosepsis or any permanent scarring or ill effects in the renal urinary system. Okay. So these are some of the treatments, and obviously depending on what the culture and sensitivity shows, we'll definitely treat the infection accordingly to the proper antibiotic to rid that patient of that particular organism. Some of the categories of meds that are given are some of your sulfonamides like Bactrim and Septra, very common types of treatments for UTIs. Your fluoroquinolines like Cipro and Levaquin, your penicillins like amoxicillin and Augmentin, and some of your cephalosporins like Duracef and Suprex. Some of the urinary antiseptics are like Macrobid. Bladder analgesics are like Pyridium, and we talked about Pyridium, how really helps to soothe and quiet down some of those bladder spasms that occur with a cystitis. But this is the medication Pyridium that really turns the urine very, very orange in color. And some of your antispasmodics like Cytospaz. These are necessary that we treat these urinary tract infections, but it's important to know too that some of them you want to be a little bit careful of, because some of your antifungal agents like Nicorel can cause blurred vision, and with your patients who are elderly that are on these, you may want to assess their renal function, because this is where most of these antibiotics are excreted through the renal system. Okay. A lot of rule of thumb is that that when a patient has cystitis, we think of treatment for the typical, 10 to 14 days or 7 to 10 days of treatment, but a lot of new rule of thumb, and some of the research has shown that with these very serious bouts of cystitis, that patients should be on antibiotics much longer, sometimes up to 3 to 6 months. As I said before, if these infections occur frequently, a cystoscopy may be done to identify any abnormalities, such as bladder calculi, bladder diverticuli, urethral strictures, or even some foreign bodies. Maybe there's some sutures up there from a previous surgery. As I said before, with interstitial cystitis, that's how we would accurately diagnose that, through a cystoscopy. And with interstitial cystitis, it's also noted that these patients do have small capacity of bladders. And one thing that's noted that's very, very identifiable with interstitial cystitis is Hunter's ulcers, which are bladder lesions. And these are also have small hemorrhages after bladder distension. So that kind of identifies that it's not your typical cystitis, that it's more of an interstitial cystitis. So these are some of the ways in which, we teach our patients, when you get the urge to urinate as soon as the call comes. Diet therapy includes all food groups, increased calories, because sometimes these infections can be quite fatiguing. Cranberry juice, avoid with interstitial cystitis. Avoid a lot of your carbonated and caffeinated drinks, and sometimes pain-relieving measures such as a cyst bath. I wouldn't lay in it too long, but it can be very soothing and kind of help promote a little bit of a relief when the patient feels sometimes those spasms, and even if the patient is having more of a hemorrhagic cystitis, which can be very, very debilitating. A sitz bath may sound very refreshing. All right, the next one is urethritis. Obviously, it's an inflammation of the urethra that causes a symptom similar to urinary tract infections. And, think about the urethra too. I just wanted to point out that, urine is supposed to be sterile, especially above the urethra. When a patient has a diagnosis of urethritis, they can have a lot of pain. It can be due to an infection by a bacteria, and around that area, around the urethra, there will be swelling. For men, at the tip of the penis, there can be discharge, burning, can develop herpes, and sometimes spermicides can contribute to urethritis. And our concern is when that swelling occurs that it could affect the lumen of the urethra and cause narrowing, which could also be an obstruction for urinary flow. With women, very similar to bacterial cystitis, but for men, the most common reasons why they have urethritis is due to the fact they might have an STD. And of course, that's going to be a very sensitive subject, because who wants to admit that? But there's a lot of teaching that will have to be done because if the male patient has a lot of partners, it would be encouraged to have those partners seek out medical attention and be treated for such also. Menopausal women may have tissue changes for low estrogen, which makes them more prone to these types of urinary tract infections. And of course, urethral strictures, narrowed areas of the urethra. Most common symptom is obstruction of urine flow. Okay. Urethral strictures rarely cause pain. Overflow incontinence can occur because, think about it, if a person is not able to urinate because of the obstruction of the stricture, they will have overflow within their bladder. Urethral strictures is treated surgically. If they dilate those strictures, it's only temporarily. It's not a cure, and they will go back to that constricted or strictured type of disorder. They can put a stent in, and also urethroplasties, which is the best chance of a long-term care. So that's all a urethral stricture is about. Okay. Why they occur? It's a great question. Could be a anomaly in the area of the urethra, but a person will notice that it's very hard to urinate, and because of the stricture, depending on the severity, will depend on how much obstruction of urine flow there is. All right, the next topic is about the specific types of incontinence. And these are definitely probably not new to you. I'm just going to go over these quickly. I may have a couple examples on the test of these. And what's important to note too is that I can't stress the importance that incontinence is not a normal part of aging. Okay, probably the most frequent types of incontinence that we see, or the most common types of incontinence that we see, are stress and urge. Okay, stress is probably the most common type. It's the loss of small amounts of urine during coughing, sneezing, jogging, or lifting. Not necessarily talking, but just if someone would, sneeze very excessively, they might notice that they lose a little bit of urine if they sneeze, or maybe if they do a more physical type of exercise, or sometimes move abruptly in a chair or get up from a chair, they might notice that they leak urine. When that happens and a woman is aware, even a man, many times there's a lot of personal pads that a woman could use so they don't soil their clothes and cause themselves any type of embarrassment. Stress continence really is probably one of the most common types that happen because a woman begins to put on weight after menopause. She may have had multiple childbirths vaginally, and then of course the loss of estrogen and after menopause really kind of weakens up those muscles that kind of contribute to being able to have complete control over urinary continence. So stress is probably the most common one. And then we have urge. It's the need to urinate as a result of bladder contractions, regardless of the volume of urine. And the interesting thing about urge is you might only have 50 mLs in the bladder, which is a very small amount. Bladder can definitely accommodate that little bit of urine, but urge is basically very abnormal contractions of the bladder causing you to just urinate at whim, and you urgently need to urinate regardless of how much urine is in the bladder. And we can kind of term this type of incontinence as overactive bladder, and you will see women have many times both stress and urge incontinence. Okay, very, very common in women who have given birth to a lot of children vaginally, and so really starts to cause overactive bladder, sudden urge to void. You can't relax the detressor muscle until they get to the bathroom. So that is stress and urge. Okay. And a lot of times what helps with that is to decrease a lot of bladder irritants, maybe avoid drinking a lot of sugary drinks, even a lot of caffeinated drinks. Okay. And then we have reflex incontinence, which is abnormal detressor contractions that result from neurological abnormalities, such as patients that have had strokes, multiple sclerosis, spinal cord lesions, things like that. So that's what reflex is. And then functional is leakage of urine caused by factors other than disease of the lower urinary tract infection. This is maybe a patient who has a loss of cognitive behavior, such as dementia. And this is where you might, as the caretaker, pre-plan their toileting schedule, because they know they have to urinate, but they don't realize that they need to do it in a appropriate place, so they might just urinate at random. So that's why, as the caretaker or caring for a family member, you may encourage them to be on some type of schedule. So you say, okay, now we're going to go to the bathroom, because they can't function properly in the regards to knowing, oh my goodness, I have to urinate, so let me walk to the bathroom and do so. So that's what functional incontinence is about.